Welcome to our webinar on controversies in strabismus surgeries. Strabismus has always been exciting with controversies and always with one or two different strategies in management. But it is important to couple the existing scientific literature and discuss with clinical experiences. So we have thus interesting topics for discussion. And I think we are all fortunate to have two great strabismologists who have mentored me, including me, in the last 20 years. And we have listened to them, to their lectures, read their books, read all their articles, and have groomed ourselves. Dr. Andrea Molinari is the Program Director, Fellowship in Pediatric Ophthalmology and Strabismus at Hospital Metropolitano, Quito, Ecuador, in addition to being an Associate Professor. She has been a mentor on cyberside for over 20 years since its inception, working with Dr. Helveston. She is also an Orbis volunteer faculty. Professor Pradeep Sharma is Professor and Head of Pediatric Ophthalmology, Strabismus, Neuro-Ophthalmology and Oculoplasty at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, Delhi, India. For all of us in India and Asia, we know him as the father of squint, as we have all grown listening to his lectures and reading his books. He has over more than 200 scientific publications and many chapters and books. He's also Orbis volunteer faculty and been faculty surgeon at the Flying Eye Hospital. I now invite Dr. Andrea to upload her talk.
Thank you, Dr. Suma, for your kind introduction. It's a great pleasure for me to share again this webinar with you, and also having the honor to share it also with Dr. Pradeep. As you all know, a Faden procedure is a special surgical technique very useful for the management of concomitant strabismus, especially in cases like this one, where the patient is orthophoric in primary position, but has a significant deviation in another gaze position. Or in cases like this other one, with significant far near concomitants, where you want the correction of the deviation only or preferably in a certain gaze position. So the purpose of this talk will be to describe in the next couple of minutes the different surgical techniques that will allow us to obtain this effect of diminishing a deviation in a specific position without affecting too much the eye position in other gazes. In a traditional Faden procedure, after opening the conjunctiva, preferably with a limbal incision, which makes the procedure easier to do over a fornix incision, the muscle is thoroughly dissected from its checked ligaments and the intermuscular membrane. As you can see here, I also placed a suture on the borders of the conjunctival flap in order to make it easier with the retraction of the flap to expose the muscle and to visualize the site of the operation. After that, the Maurer retractor is placed and the pulley is observed. The anterior part of the pulley is dissected, but only the anterior part of the pulley from the muscle, which will give you better exposure. Then a non-absorbable suture is placed carefully in the sclera and involves the outer 1/3 or 1/4 of the muscle. After tying the muscle very, very tightly, the procedure is done also on the other side. You must make sure that the suture is very well tied. Here you can recognize the vortex vein, which is always very close to the site where you have to place the sclera suture. This is what makes the procedure also a little bit more difficult. After that, a recession can be done or not, depending on the effect that you want to obtain. This procedure, together with a small recession, will help correct small angles in primary position and collapse the distance near disparity, as can be seen in this girl, in this patient. This girl was orthophoric for near and for distance after this procedure. There is a variant of this procedure called Faden stretch, in which the suture is placed in the same distant point on the sclera, but it is placed closer to the insertion in the muscle. How much closer? Well, generally as much as you want to recess the muscle. For example, if you want to recess the muscle 3 millimeters, the scleral suture is past 12 millimeters, but the muscle suture is placed 9 millimeters. This makes the anterior part of the muscle, the anterior part of the muscle from the Faden, that stretched over the sclera, which is not in the procedure shown before. This is a much powerful procedure that will correct larger angles of esotropia in primary position, as can be seen here in these two cases with a large angle congenital esotropia that needed only 3.5 millimeters recession of both medial rectus combined with the Faden to correct such large angles. There are other surgical techniques that can be used to correct concomitant strabismus, and that will have a similar effect, what we call a Faden effect. Among them, we have the bridge suture, the resect recess, the pulley posterior fixation, Faden with adjustable sutures, and the Y split. The bridge suture, also known as sanglage in the French literature, Brückenfaden in the German literature, or Faden en puente from the Spanish literature, was described by Castilla from Spain and Quéré from France. In this technique, a suture is passed from one side to the other side of the muscle without touching the muscle. And here you can compare this technique with the originally technique described by Kuppers and the Deller modification, which is the technique I showed you at the beginning of this presentation. This technique has several advantages. Among them, less adherences since the muscle is not touched, and less muscle atrophy in front of the Faden. This makes it easier and faster to perform, and also much easier for reoperations. Resection recession was described for the treatment of concomitant strabismus by Alan Scott and presented for the first time at the ISA APOS meeting in Vancouver in 1994. This technique was then popularized by Buckley and co-authors who published a much larger series in these papers. This technique is based on the fact that since the Faden produces usually atrophy in the part that is anterior to the Faden, then the effect would be the same if a resection is made on this part, and then the same recession of the muscle that was resected, and with the advantage that the recession can be done with an adjustable suture. So one of the advantages of this technique is that there is no need to place scleral sutures too posteriorly, which makes the procedure much easier to perform, and the possibility to use adjustable sutures. But on the other hand, there is also concern that the muscle might not attach properly to the sclera, since it is recessed so far back. And this is especially dangerous with the medial and the rectus muscles, where the arc of contact are shorter. This is why this technique is more useful with lateral and the superior rectus, where the posterior suture should be placed much farther back, 15 or 6 millimeters from the insertions. And also this interferes with the oblique insertions. Also, it is important to note that there are no nomograms with this technique on how much to resect and recess in order to obtain a desirable effect. The polyposterior fixation was described by Robert Clark at the 2004 APOS meeting held in Washington. This technique fixes the pulley to the anterior surface of the muscle. Here you can see with the forceps, we grab the tissue, a firmer tissue, which is the pulley, and then a non-absorbable suture is placed through this tissue and attached to the anterior surface of the muscle. This causes a mechanical restriction towards the operated muscle, which limits the muscle duction. And this is what the authors claim that makes the effect in order to correct the concomitant strabismus. You can combine this with a recession, as you can see here. 6-O-merceline is also used in this technique. And after the procedure, you can see how deductions are limited towards the operated muscle. In this other technique described by Jonathan Holmes, the muscle is disinserted, a scleral suture is placed underneath the muscle, not in the borders of the muscle as we showed previously, and then the muscle is recessed with an adjustable suture. The suture over the muscle is tied loose in order to allow the muscle to slide backwards or forwards during the adjustment procedure. Finally, the wide splitting of the muscle was described first by Dr. Jampolsky in 1980 in the lateral rectus for avoiding sliding of the muscle and improving up and down shoots in Duane cases. It was Bagolini 10 years later that describes the same technique in the medial rectus muscle as an alternative for the Faden operation described by Kuppers. In this technique, both halves of the muscles are split and separated over 10 millimeters apart. This reduces the muscle torque, thus diminishing the rotational effect. It has several advantages. It is also easier to perform. You don't have to place very posterior scleral sutures, and it produces less adherences and cicatricial tissue, which makes reoperations easier. So to conclude, we have seen that we have many different surgical techniques in our surgical armamentarium for treating concomitant strabismus. You should choose the one you feel more comfortable with, and remember that some techniques are more suitable for certain muscles than for others. Thank you so much for your attention, and I will be happy to entertain any questions that might arise. Resection and plication are alternative surgical techniques for strengthening extraocular muscles, but historically, resection has been the most popular procedure, as it was shown in the poll. Muscle plication has been described in the past, but only more recently has this procedure received more attention in the medical literature. One barrier to greater acceptance of the plication procedure is the uncertainty regarding its effectiveness compared to an equivalent amount of muscle resection. Some very well-known strabismus surgeons have found a reduced surgical success rate when using plication, as you can see in this paper, and this explains also why the poll has demonstrated such results. So this has brought some concern to whether the dose-response effect of horizontal rectus muscle plication is equivalent of that of resection. Therefore, the purpose of this presentation will be to point out the advantages and disadvantages of the plication procedure compared to the resection, and demonstrate that plication can be as effective as resection by showing the procedure I usually perform. I am convinced that the way the surgical technique is carried out in application will determine its effectiveness. In a resection, you generally resect a certain amount of muscle and you suture the muscle back to the insertion. It doesn't matter how you do this, you will get similar results. But when performing application, we must recognize that it is not the same if you fold the muscle anteriorly than if you fold it posteriorly from the insertion. the effectiveness will be different since the folded muscle in this second case will shorten the muscle in a lesser amount. There is at least 1 millimeter difference if you place this part of the muscle anterior or posterior to insertion. Let me explain this a little simpler. If you place this part anterior to the insertion, it will give you more effect than if you placed it posterior to the insertion. This might explain why some papers refer having less effectiveness and others finding both procedures equally effective. Let me show you my technique. A double arm suture, usually 6/0 vicryl, is placed at the desired part of the muscle in a very similar way as for an adjustable suture, only not at the insertion, but back of the insertion. It is very important to tie the suture in the middle in order to prevent the suture to slide backwards or forwards when the muscle is folded, as you can see here. Then the needles are passed through the sclera anterior to the muscle insertion, probably from outside the muscle insertion. You have to make sure that the muscle enters the sclera, not only the tendon of the muscle. And then you do this from the other side. And then the needle enters the muscle in front of the previously placed suture, and it comes out behind the suture. This should be done close to the muscle border. The same thing is done on the other side, if preferably closer to the border than it is shown in this video. And then the hooks are removed and both sutures are pulled up and towards the muscle insertion, allowing the muscle to fold on itself without using any type of spatula. The suture is finally tied tightly and the procedure is done. Rectus muscle plication is simple and it involves fewer steps than a comparable resection. This is a fast procedure, faster than a resection. So which are the advantages of this procedure? It's definitely faster and simpler. It does not require cutting the muscle, therefore the ciliary circulation is less disturbed. There is less surgical trauma, inflammation, and hemorrhage than a resection. It is reversible in the early postoperative period and it eliminates any risk of lost muscle. It has also some disadvantage. There are concerns, implications that the effect will not be maintained after the absorbable sutures are absorbed. In my opinion, this does not happen. There is also a cosmetic concern about a post-operative bump, as you can see in this picture taken from this paper. This does not occur when the muscle is folded over the muscle, so anteriorly. The use of adjustable sutures is also questioned. It was published in some papers like this one, but the case series are very scarce to draw a conclusion. On the other hand, it is difficult to think how a folded muscle that is partly unfolded during the adjustable procedure will adhere to the sclera. Vertical transposition of the muscle is definitely possible, although only more difficult to perform. Let me show you a video. In small plication and if the transposition is very large. Here you can see how the suture is not placed in the middle, because in the middle of the muscle there is a vessel and you want to spare the circulation. So in this case, it was placed and the knot tied in the periphery. And then the suture is passed through through the muscle from the one side to the other side. And then the difference with the other technique is that the suture is not placed here outside from the muscle insertion, but in the middle, because we want to place the transposition or to do the transposition superiorly. So in this case, the suture is placed in the middle of the insertion, and here it is placed half tendon superiorly to the border of the insertion. And you will notice that the sutures go obliquely toward the transposed insertion. Here we pass again the sutures behind the suture and then after the suture. And here you see the sutures go obliquely. Finally, you take the hooks away, and then again you pull the sutures up and towards the insertion. Finally, you tie the knot. Sometimes you need that the assistant holds the first knot with a needle holder, as you can see here, in order to prevent the knot to get untied. And here you can see how the muscle is superiorly transposed with application. So let me conclude by saying that, in my opinion, plication is as effective as resection, but it depends on the technique employed. And it has several important advantages over resections. It is simpler, faster, less traumatic, and it disrupts less the anterior segment circulation. Thank you very much for your attention.
The first question is how to identify the pulleys of the muscle.
How to identify the pulleys of the muscle? That's a good question. Well, once you get more experience, you will recognize that the pulley has a different aspect to the check ligaments, which is the ones you cut first. And then when you place the Dimar retractors, you can see a more wider tendinous aspect structure that lies approximately 10 millimeters behind the insertion of the muscle. And when you touch it with a forceps, you will feel that it is more firm.
So this is Dr. Laila Mohan. She's asking if she does pulley fixation, but she has always said that it does not have a long effect. Like when you do a Faden, it has a good effect, but she says that pulley fixation does not have a.
I agree. I agree with her. I have done the pulley fixation a couple of times, and I have seen the same thing. That's why I have not done them anymore. I agree with her. It has not the regular Faden procedure has a much long-lasting effect, and also a more powerful effect.
So you find any specific condition, maybe when the sclera is very thin or something like that, then you could plan a pulley fixation.
But in these cases, you can also do a resection.
Answer from your side, sir? Dr. Pradeep Sharma?
Yeah, I am also not very much keen for pulley fixation because I feel it is not firm structure. So you are fixating the muscle to something which is itself not firm. So that's why I think the results are not as desirable as we will get with the conventional Faden, or even with the other procedures like the Scott procedure, especially for the lateral rectus, we have seen it's very effective. Even with the lesser amounts of resection and recession, it works. Recently, I did for a medial rectus also, and I found that instead of 12 to 13 or 14 millimeters conventional Faden, I just did 9 millimeter resection and recession. It worked as well. So the resection recession procedure of Scott Buckley procedure is also a good procedure. And another procedure which Dr. Andrea talked about and I found interesting is the Y splitting for superior rectus. I think this is something which for DVD I have seen that at times you can do this procedure and it works better than a Faden for superior rectus. A Y split superior rectus, you may add with a recession. So that's another good procedure which she talked about.
That's very interesting.
Yeah, that's interesting.
I have never tried it. I have never.
Large DVD, like more than 15 to 20 DVDs. Okay.
Yeah. So if it is the superior rectus that we want to handle, I mean, those DVDs in which we find inferior-oblique overaction is there. Obviously, our choice is to do total anterior positioning.
Yeah.
But in those in which the inferior obliques are not overacting, then we have a choice between an inferior rectus plication. Nowadays, that is the preferred technique that I have. But if I have to do a superior rectus recession or a DVD, for a DVD, then I might do a Y-split along with the recession.
Dr. Andrea, you want to add?
No. I was very interested in listening to his explanation because I have never tried this technique in a DVD, but it sounds very logical to me. I will try that.
Yeah. So the other question is same thing. Would you prefer a DRS with upshoot, a Y-split, or a Faden of the lateral rectus? We all practice the Y-split. Do you do the Faden of the lateral rectus?
No, I prefer also the Y-split.
I feel in DRS when we are doing the Y-split is not actually working like a Faden. It is working more like splitting the lateral rectus and yoking the effects in the opposite direction so that the eye doesn't roll up or down, the upshoot and downshoots. So because we are spreading it much more, it's about 22 millimeters of split. So it is working more like a splayed muscle rather than a Faden. I haven't done a Faden on the lateral rectus ever for a DRS.
Yeah, sir. Yes, same. Do you prefer Y-split with shoots in severe co-contraction? Dr. Yuvika has asked.
If I prefer Y-split in
Y-split with shoots.
Yes,
we discussed in our DRS, yes.
Yeah. There's a very interesting question here, and this might be interesting for many people. How far from the muscle insertion do you do your routine Faden procedure? Because it's different for the different rectus muscles. In the medial rectus, at least you have to place it 12 millimeters back from the insertion. But in the lateral rectus, you have to place it at least 15 or 16 or even 17 millimeters back from the insertion. This is why it makes it, the Faden procedure, it makes it not so convenient for operating on the lateral rectus. And in this muscle, the recess procedure is much better to perform. In the superior rectus and in the inferior rectus, the Faden must be placed at least 14 millimeters back from the insertion.
Yes. And if the patient have with nystagmus, with surgery is good. I didn't understand this question.
Well, the Faden is
big because there are so many, you can do so many surgeries. And
I know. The Faden has been described for nystagmus. Personally, I have no experience with the Faden. I do lots of Faden, but I have not used them in nystagmic patients. I use Anderson-Kestenbaum procedures, and if there is no anomalous head posture, I usually do large 4 muscle recessions.
I think maybe it means nystagmus blockade syndrome, maybe. In nystagmus blockade syndrome, maybe that Faden could be an option, maybe, yeah. Maybe it means nystagmus
in
blockade.
Patients with congenital esotropia. Well, what makes me use the Faden procedure, what makes me choose the Faden procedure in a congenital esotropia is not the presence of a nystagmus blockage syndrome, although it has been described for using in these cases, but how I see that the angle has a more dynamic component than a contracture component. If I see that the child has a variable angle strabismus, a child with congenital esotropia, and during the anesthesia, I see that the eyes lie straight, then a Faden with a recession is very useful in these cases.
So you want to comment, sir?
Syndromes. In the Alberto-Sciancia syndrome, in which there is an adduction null. So those cases, we have found the Faden on the medial rectus along with the recession takes care of the face turn.
Yeah, well, those cases I showed, the 2 cases were Sciancia syndromes.
Okay. So there's another question. Should we do recession before placing the Faden or after the Faden?
That's a very good question.
I think you do the Faden stretch. That's
yeah, that depends.
Faden.
Yeah, if it's a stretch Faden, I place the sutures, but I don't tighten them. I first recess the muscle and then I tighten the sutures. Because what you want is that the anterior part lies stretched. If you tie the sutures before recessing the muscle, then the anterior part of the muscle will not be stretched.
Sir has a, I think has a different, sir, do you want to tell your technique? Because sir has a different technique.
No, I think what Dr. Andrea described is correct. When we want to do just a Faden procedure, then you may do the measurements prior. For example, if you want to do a 5 millimeters of recession and a 14 millimeter Faden, then I would pass the sutures in the muscle at 9 millimeters and in the sclera at 14 millimeters. And then when I recess 5, it takes into account and there won't be any stretch of the an extra recession effect. But if you want an extra recession effect, you can take into account that part. Yeah.
Exactly. I also sometimes tie the Faden and then do the recession. For example, the case I showed of the girl that had only 15 diopters, prism diopters in primary position. In these cases, I don't want a stretch in the anterior part because this will give me much more effect.
Yes, yes. Especially when you have to do a large recession, then I think it's better to do the technique where you measure it on the muscle and in the sclera you measure how much the Faden, and on the muscle you measure the recession effect.
Yeah, let me say you something regarding the amount of recession. If you plan to do a stretch Faden, be careful in not doing very large recessions, because I have had I have not very large, but I have had overcorrections when doing recessions over 4 millimeters if I do a stretch Faden.
Okay, I think other questions, I think Dr. Andrea, you'll have to answer because there's shortage of time. There are a lot of questions.
Okay.
I think you'll have to answer in the question and answer session.
I will do so.
Yeah, if any specific question, like if there is 2 or 3 questions together, then we can take that later. I'll just check the questions because these questions are keeping on coming. And anything about the plication, basically they've asked to explain how close to the border you go, how close.
How close to the border? I didn't understand that question.
I think I think they mean is that where do you take your bite in the sclera? I think what you said is a good point. You take it on near the insertion, yes.
Yes, just in front of the insertion, where the muscle is inserted, but always making sure that you are passing the suture through the sclera, not through the tendon, okay? You want an apposition of the muscle with the sclera, because muscle with sclera will attach much better than muscle with muscle.
There's a question to you from Dr. Manuela. How have you reoperated any of these patients?
You mean the plications?
Yes.
Yes, and what you find is that the muscle looks like a normal muscle. The muscle does not look thicker. That's amazing, but it's like this. It's like it fuses. All the folding muscle gets fused, and it remains just a normal muscle, like a normal muscle.
So please share your screen slide, please. I think Dr. Andrea, you have many questions. I think you should have a class only on Faden. I think at the amount of questions.
Yeah, don't worry. I would like to listen to Dr. Pradeep's talk, so I will not answer to the questions now. But I promise to remain here until every question is answered.
So the next topic we are going to cover is incompetence strabismus, adjustable versus non-adjustable. So the poll question, please. So how many of us do adjustable? So it is only in selective cases 59%, not at all 36%, and in all cases 4%. So sir can now debate which cases we should be doing an adjustable or which versus a non-adjustable.
So I think it's an interesting topic, and I really thank Dr. Suma, and it's a pleasure to be with Dr. Molinari and you on the cyber side. Since we are in the COVID times, we are all used to wearing masks, and I was just wondering that in adjustable sutures also we have similar differences of sliding noose or a 1.5 knot technique that we are seeing in the masks also, as you see here. we need to be adjustable. You need, if you don't have a Ford, you have an Oxford, and you will be more successful if you are adjustable. Adjustable strabismus surgery, if we see the history, it was first suggested by AIIMS in 1941. But if you take into account the German literature, it was mentioned by Bilshowski in 1907 when he described Sattler performing a similar procedure. It was revisited by Jampolsky in 1975, and then there has been a rejuvenated interest time and again. We need to be having this in our armamentarium because the indications will be first and foremost those which are having concomitant strabismus. If you have a sensory anomaly in which the end point is not very clear, then again we have a problem. Reoperations when the patients are more demanding, when there is a vertical strabismus or a combined horizontal and vertical strabismus, and whenever the end point is more discrete and the patient is more demanding, you would have to have an adjustable surgery. Much more so for the concomitant strabismus, which are having diplopia, and the patients would be wanting a diplopia-free position. So whether it be a sixth nerve, fourth nerve, or third nerve, or even in the restrictive strabismus, particularly the dysthyroid eye conditions, or an ortho DRS, which may be a very troublesome thing if you do not have an adjustable on your sleeve. Post RD buccal surgeries or glaucoma ball surgeries are again very definitively demanding, so we will have to do. The contraindications, of course, are those children who are not going to cooperate. Even apprehensive adults who behave like children may be uncooperative. High myopes, thin sclera, or an inferior rectus, we may have a problem, and we have to be careful that we don't use an absorbable suture, otherwise there is a progressive recession. The published studies on adjustable surgeries are inconclusive. As you see, there are 18 studies described by Nihalini and Hunter in the eye in a very good review in which they have shown. But unfortunately, you'll find that mostly are retrospective, non-randomized, and the numbers are not as much to give us a definitive answer. Even the Cochrane review, again, time and again, even in the latest one recently done, has been inconclusive, and it doesn't tell us because there are no randomized controlled trials between these two. But whatever studies we have seen definitely show that the success rate improves between the non-adjustable and adjustable, and a difference of at least 10% jump is there when we use adjustable surgery. So the reoperation rates fall from 20% to 9.7% as shown by Wisnicki, and definitely we can adjust at the time up to 20 prism diopters at the adjustment. So whenever you have a demanding patient in which we want an exact result, whether it be for a cosmetic reason or for a diplopia free, you would have to do this technique. Let's see what are the different strokes that we are going to play. First of all, it may be preferable to do a limbal incision, although it can be done with the fornix incision with a retractable suture placed to help you expose that. Secondly, we are going to pass the sutures, the needle radially as shown here. It may be a full hangback or a hemi hangback, in which, like in this case, we are showing you a hemi hangback in which we have passed in the sclera and then again in the insertion side. The third thing is that I am going to place a releasing suture, a silk suture between the sclera and the first knot, so that it helps me in releasing the knot at the time of adjustment. You need to see that your suture moves in the tunnel. So check that at the time of surgery so that it makes your life simpler. And this 1.5 knot I am placing instead of the regular one. The silk suture is tied as a loop knot. And finally, we have a bucket handled suture, which will help me hold the globe and not depend on a fixation forceps. Sometimes the tissues can be cutting through with the forceps. So you need to have a firm grip on the sclera. So these are the few different techniques or strokes that we'll play. There are different techniques of adjustable strabismus surgery. It may be a hemi hangback or a full hangback as in shown A and B, or it may be a sliding noose technique as preferred by some people. When do you adjust? It may be done intraoperatively as a single stage adjustable surgery using topical or IV conscious anesthesia, or it may be done as a double stage, which is a more commoner method. It may be done after 5 to 6 hours, although some people do it between as 2 sequential GA, and even after 1 hour adjustment may be done. After 24 hours has been also done by some people, and there has been a study by Valley's group who have shown that there is not much difference between 5 to 6 hours or 24 hours. Even delayed techniques have been described. The technique that I usually follow is what I learned from Dr. Rosenbaum, And the simple instrument that you will require for adjustment are shown here. You may require a tetracane or a paracane drops. If you find the pre-op patient who had an exo has gone into a post-op over or under, you can adjust it accordingly. You just need to release the 1.5 knot, and for decreasing the recession, you hold the globe and pull the suture so that the recession can be reduced. Or if you want to increase the recession, you hold the globe and ask the patient to contract that muscle so that it recedes further. So both are possible, and for this reason, you may do an optimal surgery and not do an over recession as it was initially mentioned by some people. The sliding noose technique is another technique, but my preferred technique is the 1.5 knot, and that is what I have shown here, and we can do it. In children, Hakim has shown that you can do a 2 more millimeter recession, more effect which can be added, and this can be released by the releasable suture, and you can have like 2 options. Similarly, Helveston has shown as a tandem suture technique which you can have. The Faden has also been used as an adjustable suture, as we were just talking about by Dr. Molinari's talk, and this is especially so when we have a near distance disparity, when we want a more exact end result. Similarly, the superior oblique tuckings, we always do an intraoperative adjustment. This is also considered as an adjustable procedure in a way. And the Harada Ito can also be done as an adjustable procedure to get the end result of torsion more accurately positioned. Coming to the 6th nerve pulses, which we'll be talking about more detail in my next talk, the adjustable cross-section partial VRT as shown here is a very definitive advantage compared to the non-adjustable, in which you may have either an over or under correction which may not be desirable by the patient. And as shown in this study, in these 10 cases in each group, we found in the adjustable, there was only 1 case which was 8 or all were less than 8 millimeters prism diopters. Whereas in the non-adjustable group, we ended having 5 cases and we could not adjust. So it is always better to have an adjustable technique on your sleeve. So to conclude, adjustable sutures provide a more definitive alignment. It requires a special technique, extra efforts are required, and you may not require to adjust in about 50% of cases when you are doing an adjustment. It is definitely a double trouble, but in demanding cases of diplopia, it offers a second chance or a safety net to fall back upon. So I would say whenever you have a very demanding patient, you should try to do this technique so that we can definitely give an alignment in each type of surgery that we do. Thank you.
Thank you, sir, for an excellent presentation. The questions, I think the questions are coming in, but one question which is written is that, Sir, Dr. Yuvika has asked, sir, has you pointed IR as a relative contraindication? Can we do IR recession and adjustable in thyroid? We do adjustable in the inferior rectus and thyroid.
Yeah, you can do adjustable. What I mentioned, when you have to do a adjustable on a inferior rectus, it is preferred to use a non-absorbable suture, especially in thyroid cases, because you may have a posterior slippage or over recession effect over a period of time. This has been reported by several people. So it's preferred to use a non-absorbable suture when you do a thyroid inferior rectus. A tight inferior rectus against the bells, which usually tends to recess more.
So there's no question, but sir, do you find the noose technique, the 1.5 technique better than the noose technique? Any special, why you switched? Because I was doing the noose.
In the noose, I have a fear that it may slip beyond my control. Okay. So because of the
tightness, I feel in granuloma, the noose technique was a concern. Do you?
Okay, so that's why I usually do not do a noose technique, and I find a 1.5 knot can be easily pulled forward or backward and give a final end result. So I usually prefer to do a 1.5 knot. But yeah, there are people who do a noose technique, and it's fine with them.
So there's a question they're asking you, how much do you split the muscle for Faden? I think this was for the DVD. How much you are going to split it for the superior rectus?
I would have to split at least 10 millimeters. And the separation between them is not as much as we do for a DRS. That is 20 millimeters for DRS. Here the splitting between the two ends of the superior rectus is about 8 or 10 mm. Because this is what we just need to do a Faden effect. So now I will be talking about the vertical rectus transpositions and the modified Nishida procedures for abducens palsy. I have no financial disclosures to make. The management goals in 6-nerve palsies, as we all know, are to bring the eye to the primary position, to correct the head posture in the same manner, to provide diplopia-free vision in the primary gaze, to improve the abduction amplitudes, and finally to expand the field of binocular single vision. So let's say if you have a 6-nerve palsy, we have seen the transposition procedures have evolved over a period of time. In 1907, Hammersheim had described the partial VRT. There have been several modifications since then, and each one has added value to it. Whenever we have a partial VRT to be done, we know that the effect may not be as much as desired. So there have been techniques to augment the force by adding a resection to the component of the muscle which is being fixed, or Scott Foster suture, an augmentation done by posterior fixation suture, which is past 8 millimeters to vectorize the force in the direction of the paretic muscle. This has also been done for a partial VRT as well as for a full thickness VRT. And there is an article from Velez Rosenbaum group in which a partial VRT with posterior fixation sutures were shown. But the problem with these techniques is that there is no ability to adjust. And if you have a desired result, it is fine. But as we have seen, it may not be all the times. And you may sometimes have an under or an overcorrection. And even an overcorrection may not be so desirable as the patient will be unhappy. So Guyton described a technique in which he was using a cross-action, full-width vertical rectus transposition so that it could be put on an adjustable suture. And this is a very interesting technique. But since we are using a full width, there is a risk of anterior segment ischemia, especially if you have to add a medial rectus recession as the antagonist muscle. You would have handled 3 muscles. So we thought that why not do it with the partial VRT. So what we have described is a partial VRT on cross-action sutures as shown in this schematic diagram and the picture here. I will just show you a video which will show you first the conventional VRT, a partial VRT using a resection to augment the effect. So this is what we have split the superior rectus. Usually we try to save the vessels as much as possible, and sometimes even this half of vessel may be saved. Now 2.5 millimeter resection effect we have developed in this by passing the sutures 2.5 millimeters away from the insertion. So we will be effectively resecting this part of the muscle. In any case, whenever we are using the superior rectus for lateral rectus, there will be an augmentation because the arc of contact will be stretched when we are putting for a lateral rectus. And now we are passing the superior rectus at the upper edge of the lateral rectus. Now this is how we can do a conventional partial VRT. Similarly, the inferior rectus is passed, and as I have shown you that it can be put on an adjustable suture intraoperatively or even as a 2-stage. You can keep it as a 1.5 knots. This will also help in correcting any torsion effect or a vertical effect. For a cross section, the technique is similar. You just bring the superior part on the inferior end and the inferior part on the superior end of the lateral rectus. As you see in the schematic diagram here. And you can put them on an adjustable suture, or if you're confident, you may put it as a non-adjustable suture and do only an intraoperative adjustment to see that there is no torsion or a significant vertical deviation that you have created. But if you have to be more sure, you can keep them on adjustment and adjust it after 6 hours. We had done a study comparing the adjustable and a non-adjustable group. As you can see here, the pre-op large angle exotropia which was there has been corrected fully. The abduction has improved and the distance deviation was improved in both the adjustable and non-adjustable techniques. And similarly, the binocular vision was also improved, but it was larger improvement or more improvement in the adjustable group compared to the non-adjustable group. And similarly, the abduction improved in both the groups, but slightly better in the adjustable group. So coming to the dinner plate that you have now, the options that you can have a partial tendon VRT, a full tendon VRT, or you may have a single muscle SRT or an IRT. as described by Hunter's group. You can also add on the effect by augmenting by a resection as shown here, 2.5 or 3 millimeters. You can add an effect by a Foster's sutures, or you can also augment by a cross-action suture. You can also increase your effect by doing an antagonist medial rectus recession. Sometimes if you have a full VRT, you may not be able to do a recession. You may just use Botox in the medial rectus. And you can also have a additional effect by doing an lateral rectus plication. So you have a full plate for your dinner right now, but this is not enough. We have the dessert still left, and that's the Nishida's procedure. So the Nishida's procedure is a very useful addition to our armamentarium that we have. Here we are not disinserting the superior or the inferior rectus. We are not even splitting the superior inferior rectus, but just vectorizing the force, passing a non-absorbable suture, 8 millimeters in the muscle, and then putting it closer to the muscle that we want the effect to. And these are the pre-op and the post-op pictures. Let's have a video to see how it works. So in these two vertical recti, the same way as we did for the VRT, we are going to identify and free it up to 8 millimeters, mark it at 8 millimeters. Non-absorbable 5-0 ethibond suture is what I like to pass in the 1/3, lateral 1/3 of the superior and the inferior rectus. We also need to ensure that the nasal part of the intramuscular septum is spared or freed fully so that the muscle can be easily switched towards the side that we want to switch. And then 13 millimeters from the limbus in the sclera, a passage is made and with both the needles. And then again, I pass it in the muscle. So this is a muscle, sclera and muscle technique again, which will reinforce the vectorization fully in the direction of the absent muscle or the weak muscle. This is a very simple technique which is being initiated by Dr. Nishida's group, and we have modified it slightly that we vectorize a little more towards the missing muscle, and the effect is very good. It can correct up to 35 to 40 prism diopters easily. And as we have seen in this study, we'll close this here. This is the pre-op and post-op pictures. In the non-adjustable group, when we did the Nishida's procedure, we found that we had overcorrections in several cases. And in one case, it was very severe to about 30 prisms. So we need to have an adjustable medial rectus whenever we do a Nishida's procedure in order to have a more definitive result, as we saw in this group, in which the adjustable medial rectus recession takes care of the overcorrections. The preoperative fields have been centered and enlarged in the dimensions. The abduction amplitude has improved, and the anterior segment ischemia has not occurred, which we should be always careful in all the VRTs and examine the eye under the slit lamp on the first post-op day so that there is no anti-segment ischemia signs. The series that we have seen in the reviews, there are several studies which have been done. We have found that because the techniques are so different and each one does it a little differently, there is no conclusive answer. But we definitely know that the single muscle techniques are less effective than the double muscle techniques. The partial vertical rectus transposition will be less effective than the full width transpositions, but there is a risk of anti-segment ischemia. So our choice would be to use an adjustable cross-section partial VRT to get a more definitive and predictable correction, and in addition to the medial rectus recession. And in the Nishida's group, whenever we are doing, and we may have an adjustable MR whenever it's possible, like we are operating on an adult or a cooperative child, this would be our preferred technique. So to conclude, I would say you need to have different techniques in your armamentarium. As this study has shown recently, and I also have seen once that I had to do, when I was doing the partial VRT, the inferior rectus partial stump just gave way, and I was under a dilemma what to do. So I used the inferior rectus Nishida's technique, and the superior rectus was of course done with the VRT technique. So you can have a combination of different techniques to get the desired result. I would like to thank you at this point and for your questions. Thank you.
The questions is like, what is the ideal age for VRT?
We have done in children, maybe even a child with 3 years old, I have done a VRT, as well as the lateral rectus split and medial positioning also I have done in 2.5 or 3 years old children with a large third nerve palsy with a large exodeviation. But in 6 nerve palsies, again, if you have, fortunately we do have less 6 nerve palsies, but when we have a DRS cases, we may have to may do children also in with the VRT in younger children.
There is in modified Nishida, how do we achieve shifting of the muscle without splitting? I think it's your modified technique which they're asking.
Yeah, what we need to ensure is split the intramuscular septum on the nasal side so that the superior rectus can be easily transferred towards the side that you want. And secondly, you need to pass a reinforcing suture. That means first in the muscle, then in the sclera, and then a bite in the muscle again. This will bring the muscle in the desired position. But we need to free the intramuscular septum on the nasal side.
Okay, so I'll start sharing my screen. I would be speaking on, I think, a surgical controversy, which is a simple topic, but I think we always have this whenever we are dealing with intermittent exotropia. So we know that intermittent exotropia is a common form of childhood exotropia, accounting for about 50 to 90% of all the exotropia. It is characterized by intermittent divergence, which is usually present initially on distance fixation or when the child is tired, but later at near fixation as well. So it can worsen or deteriorate into a constant exotropia, and this can affect the stereo vision and cause amblyopia. So we have the classification systems, that is the Burian's classification and the Kussner's classification. We do follow these classifications for our management. So the indications for surgery are a constant deviation, a deteriorating fusional control, large angle deviation, or if there is a reduction or loss of stereo acuity for distance and near. I will go to some basic cases. Now, this is a case 1, which was a basic exotropia with 35 prism diopters for distance and also 30 prism diopters for near, 35 with alternate suppression with a stereops of 800 seconds of arc. Post-operatively, after doing a bilateral lateral rectus recession, we got a small residual of 4 exo. But the distance and near, we had good BSV and stereopsis increased to 200 seconds of arc. This is another child with 30 prisms exo and 25 prisms near exo. Alternate suppression, the stereopsis 800 seconds of arc. Performed a bilateral lateral rectus recession. We got a distance and near 8 prism diopters esotropia. But same, but for distance was suppressed and for near BSV. Stereopsis 400 seconds of arc. Case 3, 50 prisms exotropia, and for near also near was 35 prisms. On patch test after 1 hour, the child near deviation increased to 50 prism diopters. So it was pseudo divergence excess. Again, this alternate suppression and stereopsis absent. Performed a right lateral rectus recession with a medial rectus resection. Small residual exotropia, but good sensory outcome. Similarly, a basic exotropia case, an older male 20-year-old with a 45 and a 50, and there was a residual of 12 prisms exotropia on the first month, followed by fusional exercises. He improved to around 4 prisms with good stereo fusion for distance and near. So the goals, we know that the choice of surgery for basic exotropia is both lateral rectus recession or unilateral lateral rectus recession and a medial rectus resection. So now what we want to know is which is more effective in terms of long-term success rate, overcorrection rate, or recurrence rate, or drift. So what is the success rate for each procedure? What are the factors affecting the outcome, like the age of onset, duration of deviation, amount of pre-op deviation and post-op deviation, presence of amblyopia, anisometropia, or lateral incompetence. So this is review of literature. There's a paper published on the meta-analysis done 2018 regarding these 2 procedures. A comprehensive literature search was performed using PubMed, Embase, and the Cochrane library. They found very few randomized controlled trials for knowing the effectiveness of both the procedures. But then they evaluated in terms of long-term success rate, overcorrection rate, and recurrence rate. They had a very fixed selection criteria. They only chose basic exotropia cases, and in whom there was a clear-cut definition of success, and whom one of the primary outcome measures could be extracted. So out of 2,544 cases, it's published literature, coming to the strict criteria, only the studies which they included were ultimately only 9 studies, because most of the other papers did not give a clear-cut definition of success. And what they found, the success rate of the two kinds of surgeries was comparable. The overconnection rate was also the same. But if you see the recurrence rate, they found that bilateral lateral rectus recess had a higher success rate after follow-up of more than 2 years. But R&R had a better outcome, less than 2 years, but they definitely showed an exo drift in the long-term period. So this was so, but for small angle, they found that R&R had a better outcome than unilateral lateral rectus recession. So and other papers also which published in 2012, which they again took basic exotropia, but they chose different angles. Like for a bilateral lateral rectus recess group, they chose larger deviation, 40.5, and the RR group was a smaller deviation. And they preferably chose the eye with a dominating fixing eye for RR. But still they found that they had a higher success rate in the bilateral lateral rectus recession group, and none of the other factors were associated with recurrence. But they found that the survival analysis, if they see, was better in the bilateral lateral rectus group. So other paper where they took the ether, because there was a difference in the deviation, this group had both as lateral rectus and the RR group with the same amount of deviation, the number of patients and they found that the RR group showed higher rates of success when the deviation was more than 45 prism diopters. So the pre-op deviation, if it is more than 45, so they found that with the bilateral lateral rectus, there was a recurrence of 35.6%, and which was less with the R&R. And so this is how they concluded that maybe for a more than 45 prism diopters, you need to do a R&R surgery. They found the prognostic factors, they studied whether the age at surgery, and they found that recurrence rate decreased with increased age at surgery. And they found that the recurrence rate also increased with increased deviation of immediate post-operative period. Similar, they found with the recurrence with unilateral recess and resect, but they found that with the bilateral recess, there was 72.6 success rate, whereas with the unilateral, they found a success rate of 42.7%. And the older the age, the larger the decrease in recurrence rate. So the take-home message and maybe the points for discussion would be, how many of us actually do a recess, bilateral lateral rectus recession? What is our criteria? If it is more than 45 prisms, we mostly go for a unilateral lateral rectus recession and resection. And what is the survival probability in the bilateral lateral rectus group has shown a long-term effect. So recurrence rate and a higher success rate is seen in the bilateral lateral rectus recession group. So the other discussion was, I think the other controversy which we have is the A and V patterns. Whether we go in for a vertical transposition of the horizontal or the oblique muscle surgery. So we all know that AV patterns form around 5 to 25% of all our strabismus practice, more seen in esotropia than in exotropia. So A pattern, this is basically we all are aware of that it is taken significant when it is around 10 prism diopters, and V pattern is taken significance when there is 15 prism diopters. So the etiological factors have all been reported in literature as oblique muscle dysfunction, horizontal rectus muscle dysfunction, vertical rectus muscle dysfunction, orbital factors of the pulley concept. So most of us practice that we go in for the oblique muscle dysfunction present or not. We also find that in neurological involvement and malformative systemic disorders in A and V pattern, we find A pattern showed a greater prevalence of neurological impairment, hydrocephalus and meningomyelocele, whereas V pattern was seen mostly in craniosynostosis and malformative syndromes. So our strategy at present is oblique muscle dysfunction present, then we do oblique muscle weakening. If it's not present, we do vertical transposition of the horizontal muscles. So the effect found by weakening of the inferior oblique muscles, it corrects around 15 prisms to 25 prisms of the V pattern. And graded anterior recession, anterior transposition of the inferior oblique, it is also found to get good effect in 82% of cases of esotropia and 80% of exotropia cases. But the response was mostly depend on how much is the extent of the preoperative V pattern. And also they found that even if you do a bilateral recession of the inferior oblique, they got a good outcome in this paper, they said that there was a vertical imbalance post-operatively, but we normally find that if there's an asymmetric vertical in the primary position or in the side gazes, we do asymmetric inferior oblique recession. So similarly, in A pattern, when there is a superior oblique overaction, we normally go in for a superior oblique tenectomy, the posterior tenectomy of the superior oblique. And it has found to be effective in A pattern around 15 prism diopters, and it reduces it to a mean reduction of 12.75. But it does not have any effect on the primary position vertical deviation as well as ocular torsion. So, and this paper says that the dose is what, all the doses is, there is a uniform dose and it collapses the A pattern. But if there is no oblique dysfunction, what we do is a vertical transposition of the horizontal rectal muscles. So we shift the medial rectus to the apex and the lateral rectus to the base. Dr. Pradeep Sharma et al. Concluded in his paper, which is published in the Indian Journal of Ophthalmology, that a 5 millimeter shift was as effective as an 8 millimeter shift in monocular vertical displacement of horizontal rectus muscle. We find that a half muscle shift yields around 15 prism to 20 prism. So this is what, if there's an exotropia, we shift the lateral rectus upwards and the medial rectus downwards. So the controversy is whether we do a horizontal muscle transposition or oblique muscle weakening for correction of the patterns. Why this controversy is because the paper published in 1998 by Dr. Clark, R.A. and the group of Dr. Rosenbaum and Demmer, they found that the description of connective tissue sleeves that function as pulleys for the rectus muscle, they are responsible more mainly for the abnormalities of the extraocular muscle pulley position. And it is the pulleys which determine the paths and thus pulling the direction of the extraocular muscles. So the pulley heterotropy should be considered in the differential diagnosis of concomitant strabismus and oblique dysfunction. So whether to do a transposition or whether to do strength weakening of the oblique muscle. The pulley concept says that in the V pattern, there is a downward displacement of the lateral rectus muscles, pulleys, and upward displacement of the medial rectus when it's a V pattern. And for an A pattern, there's an upward displacement of the lateral rectus and downward displacement of medial rectus pulleys when there is a A pattern, or also a nasal displacement of the superior rectus. So we found a similar case which we had done where we didn't touch the oblique muscles and also the shifting of the lateral rectus. In a 35 prism exotropia with a DVD, just by doing a lateral rectus recession and a superior rectus recession, we found that the A pattern was crushed. So, so this is another paper where they have shown that high resolution surface coil MRI scans done in contiguous quasi-coronal planes tell us about the rectus muscle locations. And this should be always looked for in cases with A pattern or in A pattern. So this is what they found, that there is always there is a displacement of the lateral rectus and the inferior shift of the medial rectus, like in an A pattern or in a V pattern. So now the questions I have is that, so if this is a patient of craniosynostosis, operated already right eye with lateral rectus recess with medial rectus resect, had still a residual of 35 prisms exotropia with 16 prisms left hypertropia. And there is a 64 prism V pattern. We know that the causes are axial torsion of the globe, anomalous vectors of muscle action, or a shorter orbital floor. And it is said that in these cases, we need to look for do an MRI and look for the displacement of the muscles. So maybe in this case, we should be shifting the lateral rectus and the medial rectus for a V pattern along with the inferior oblique also when we do because since there is also an oblique overaction here. So Dr. Zia Chaudhary and Dr. Demmer had published this, and they found, and they have concluded that pattern strabismus and congenital pulley heterotropy is correlated with abnormal pulley locations of the horizontal rectus muscles, and they may not be due to oblique distal muscle dysfunction. So should we be doing MRI in all patients of A and V pattern, or is there only specific cases? I would like the poll question to be put, Dr. Lawrence. How many of us do MRI in all the cases of A and V patterns? And do we ask for a specific MRI? So the verdict is in selected cases and not at all in 31% cases. So we're done with all the presentations. Now we will take over the questions.
I have a question for you, Dr. Suma, and for Dr. Pradeep too, regarding the effect or the position you look for when operated on intermittent exotropias. Have you found that the exoshift is different in children and than in adults? And for example, I always look for a small overcorrection of 5 or 10 diopters in children, but not as much in adults, because I have seen the adults don't have such exoshift. What is your experience with this issue?
In children, we aim for an overcorrection because what I've seen is that now since into long-term practice, we find that after 3 years, if we have not, if it has remained ortho, or if it has remained even in slight post-operative deviation, you have still an exo remaining, I find that they drift. And then you have to add on a medial rectus resect maybe after 3 or 4 years. So it is better to keep them overcorrected. I used to first follow Dr. Rab, where he said that you do around 10 to 15 prisms ESO correction. But I found that parents are very unhappy. So I left them around 6 to 8 prisms ESO. But it is not very predictable. You aim for a 6 to 8 prisms ESO. It is not in all cases you get that. That's what I like in all the cases which I showed. It is so you aim for an ESO, but you aim for an overcorrection. Adults, I prefer to go for an ortho or an undercorrection. But again, there's a drift. So basically, you see if the patient is, I think if the patient has no fusion, then I would aim for slightly overcorrection, because then you cannot work on it even for getting, you cannot even do the exercises. But if there is some amount of fusion, which I check on synaptophore whether the patient has a fusional potential, then I do I make it slightly undercorrected so that we can work on the fusion.
Dr. Pradeep?
Yeah, I have a little different take. Children who are under 5 or 6 years of age,
yes,
I would avoid doing an overcorrection. And secondly, I find in children there is the yield is much more than what we get in adults. So if you end up having a consecutive ESO in a child, the risk of amblyopia is much more severe to bear with, rather than having a residual exotropia in which they can still fuse in intermittent divergent squints. So I usually try to never overcorrect in under 5-old children. I would aim for an ortho position or even reduce a little bit so that I get an undercorrection up to 5 years of age. Older children, yes, about 6 or 7 years, and adults, I would overcorrect so that I get about 8 to 10 prisms of a ESO on the first day. I have seen this exo drift is maximally happening in the first month, and then after that the shift is only about 2 to 5 prisms. Secondly, to Dr. Molinari's question about the drift, I do see it in adults also. Even in older children who are about, intermittent divergent squints, many a times we are operating around 25 to 30 years also. They do have a exo drift. And that is the reason why many people have a feeling that we should not be operating in children and we should be operating only at the marriageable age because it will always come back. It doesn't actually come back. It's an exo drift. If you correct it in an older child and adult with an ESO end result, you will not have a loss of the correction. You usually end up having the same thing for long term. So you should overcorrect for adults and older children, but less than 5 or 6 years, I would say never overcorrect.
Yes, actually less than 4 years in intermittent exotropia, we do wait. I don't go in for a surgery so early. So that's also other, I do try the other factors like an alternate, over minus lenses till 4 years of age, till we get the full proper deviation from the parents, from the child.
But we have to, I think I would rather do a residual exo as an age.
Yes. If it's a younger age, yes.
I agree with you, Dr. Suma. I try not to operate under 5 years of age, actually.
I think Dr. Pradeep Sharma has a talk, then I'll see my questions. Could Sir Pradeep give comments on NAP full tendon transposition?
Okay, I didn't talk about NAPS because the topic was only VRT for a sixth nerve palsy. NAPS is using a similar principle, but we are using horizontal rectus transpositions for a vertical muscle palsy. So NAPS procedure is a different procedure, although in principle it may be similar. So we do use a NAPS procedure for double elevator palsies or monoocular elevation deficits. We can use the horizontal. The good thing about a NAPS procedure is when we are doing a full width horizontal rectus transposition, the risk of entry segment ischemia is not much. Because the horizontal recti, there is a long posterior ciliary artery also to contribute. So the risk of doing two muscle surgeries is usually not as much as when we have a vertical rectus transpositions. Even with just two muscles and not the third muscle added on, there is a risk of entry segment ischemia.
Okay, questions. Dr. Andrea, okay. They've asked is suppression in a child, when do you plan surgery? I think one of the indications for surgery is suppression. So if there is suppression, I would go for surgery unless the child, even if the child is very, like say 4 years of age, if the child is going to suppression, I would do patching for some time. I would wait for some time and then go ahead and do the surgery. But I think in more than 4 years of age, suppression is an indication that you need to go for early surgery as soon as you see.
We should avoid having suppression, yes, because then we are losing binocular vision. If
yes,
we have
yes,
a child already suppressing, then he's going to have loss of binocular vision, even though they may have 6/6 vision in each eye, but they may be having an alternate suppression, which may not be a desirable result.
Yeah. So
there is a question regarding the Faden on the inferior rectus for inferior rectus paresis. The question is, what is the role of Faden on the normal muscle like inferior rectus in cases with inferior rectus paresis, I guess on the other side? Can it create a matching defect and improve depression in the affected eye? Well, it's exactly, this is one of the indications of a Faden for the inferior rectus. It will not improve the pressure. Well, if it's a paresis, yes, it might improve the depression in the affected eye, definitely. But what it will mostly do is restrict depression in the muscle where you perform the Faden.
It may have a fixation duress effect. Yeah, getting more innervation to the conjoint movements if you have a Faden on the contralateral inferior or superior rectus. Yeah.
There is a question for Dr. Pradeep. For large exotropias, which is better? Both, that the question is for Dr. Pradeep. What do you think in large exotropias? Which is better, bilateral recessions or recess-resect?
Yeah, what I have seen is that the R&R definitely gives a better effect and also a more lasting effect than the bilateral recessions. And whenever I have to do a bilateral recession, like in a child, maybe when we are doing under GA and it's an alternating eye, I do bilateral surgeries. I usually end up having more amounts than when I would be doing an R&R. So R&R, I have seen, it gives me about 20% extra effect compared to the same millimeters for a bilateral recession.
I agree with you on that, but on the other hand, what makes me opt for a bilateral recession instead of an R&R in many cases is the cosmetic effect. I have seen that the palpebral fissure can be affected, and this will, especially in adult patients, especially in women that are very concerned about their cosmetic aspect, that the bilateral recessions are cosmetically better than R&R.
Yeah, I would agree that whenever you have an alternating exotrope, you can and you should do a bilateral recession. But if you have a unilateral squint, always having a unilateral exotropia, then my mentor told me that the principle in strabismus is to do a symmetrizing surgery, not always necessarily a symmetrical surgery. So if there is a pre-existent asymmetry, do an asymmetric procedure to restore the symmetry. And if there is a symmetry already, then you can do a bilateral recession.
I think is Nishida's procedure good enough in place of naps?
Yes, Nishida's procedure can be used in place of naps also. There are some studies, and even we have used it, especially in cases when suppose there was a tight superior rectus and I have done a recession of the superior rectus and the inferior rectus was because of trauma already injured. Now in such a situation, it may be better to do a Nishida's procedure on the horizontal recti so that we do not risk entry-segment ischemia. So it is a question.
Questions regarding plication. Does the formula, is the formula similar or the indication similar to R&R? Yes, because in my hands, plications give me exactly the same result as a resection.
I would agree.
How long does it take for the bulk of the plicated rectus muscle, plicated part of the muscle to flatten?
I think 3 to 4 weeks maximum.
Agree.
The 3 to 4 weeks, Dr. Farooq has written. So 3 to 4 weeks.
There is another question regarding if the Faden is a bilateral or unilateral procedure. That depends on the indication. For example, if you are going to use a Faden for a vertical incomitance, you do it only in one, like we talked before for the inferior rectus paresis in one eye, you do it only on the inferior rectus of the other eye. But if you want to correct an exotropia with far distance incomitance, you do it in both medial rectus.
How much maximum bilateral rectus recession one would perform? It's a question to Sir. Like I preferably don't like to do more than 9 or 9.5. So do you do a 10 to more than 10?
Yeah, I wouldn't do for, if I have to do more than that, I would rather do an R&R. Because as I said, R&R will give me a better yield. So maximum I go is 9 millimeters in committant squints. And if you take care of these numbers, you would not have the palpable aperture changes also. Because you should be balancing the lateral and the medial rectus effect so that there is a rotational effect on the globe rather than a retraction effect. So you should do equitable amounts of recession and the resection of the medial rectus and lateral rectus so that you do not have a palpable aperture change.
Yes. Even I find sometimes there is a minimal limitation if you do more than 9 and 9.5. And so we could go on to the third muscle if we have to do more, or a recess resect.
But very large exotropes, you may go up to 12, and there are some articles coming from, I think, China, in which they have large angle exotropes corrected by these 12 millimeters of LR recessions and 7 or 8 millimeters of resection. So those may be having some incomitant pattern, and in incomitant squints, you may go beyond the normal.
Like in a third nerve palsy, we do large recessions of the lateral rectus and the medial rectus.
20 to 25 millimeters of recession.
Yes. Dr. Andrea, this is for you. Which one do you prefer for high AC by ratio esotropia? Faden procedure or slanted recession?
Faden procedure.
Yeah.
Because I was taught.
Faden over a bifocal?
Yes, definitely. Yeah, over a you mean no? The question
she
was
asked you for the, I think Dr. Adina has asked you whether it's slanted recession.
Yes, no, I prefer the Faden procedure, but I understand the slanted procedure is much easier. The thing is, I was trained in Argentina and in Germany. In Germany, the Faden procedure is very popular. So since I learned the procedure and I did it so many times, it is not a difficult procedure for me. But this is why I said in my conclusion slide that you have to use the procedure you feel more comfortable with. And if you feel more comfortable with the slanted recession, then you should choose that one. But in my hands, a Faden procedure works very well, but I am very used to do this.
For a high AC by ratio or a sorry, sir?
Through a commutative AC by ratio, you may use bifocals.
Yes. Like, do you go in for a Faden or you go in for the convergence excess type with the Faden? Dr. Andrea?
I didn't understand your question.
Like if a patient with the bifocal is performing, you can make it ortho with the bifocal by giving an
No. If the patient gets corrected with a bifocal, I use a bifocal. I don't do a Faden, of course.
Non-accommodative convergence excess esotropias.
Yeah. I think the last question we'll take on is, do you use non-absorbable in inferior oblique or any restricted muscle?
Inferior oblique, why? Inferior rectus, I had mentioned.
I think this is a question from Dr. Ibrahim.
Non-absorbable sutures. Superior obliques we do use whenever we are doing a loop tenotomies or loop hangback for the superior oblique. I use non-absorbable sutures.
I think the question comes because, for example, there is some authors say that the inferior rectus tend to slip back, and this is why some authors, I think Irene Ludwig, I'm not sure, she recommends to use non-absorbable sutures for the inferior rectus. Personally, if I use non-absorbable sutures.
I have a question for both. For an A pattern with torsion, which is the procedure you prefer? You do a chicken suture or a superior oblique tenectomy?
For
an torsion associated.
You mean for a superior oblique overaction with an A pattern?
With A pattern with torsion, what would be a procedure of choice?
Which is not a Brown syndrome, exactly.
No, this is not a Brown syndrome. This is an A pattern with a superior oblique overaction, like an inferior oblique paresis.
I do a superior oblique tenectomy, approaching it from the temporal side.
Okay.
Dr. Pradeep?
Superior oblique overaction, and it's not, the torsion is not much. It's a mild superior oblique overaction. In A patterns, I would do a posterior tenectomy of superior oblique. But if it is a more severe 3+ or 4+ superior oblique overaction, then I usually nowadays do a hangback superior oblique recession. That is loop tenotomy, which gives me a more graded result for the superior oblique weakening.
Okay. How do you make sure, Dr. Pradeep, when you do a recession with a hangback, that the superior oblique tendon really goes far back because of the frenulum? Are you very careful in cutting all the attachments?
Quite right. You need to separate the frenulum between the superior rectus and the superior oblique, and see that the muscle the tendon has been freed, and you can move it back and forth and see that yes, it is there. And then at the end of it, you will do a force reduction, exaggerated force reduction test to ensure that the superior oblique is stretched and retracts back. That's right. Unless you do the separation of the frenulum, you may not have the desired result.
I think it's past time. Thank you, Professor Pradeep Sharma and Dr. Andrea. This has been a wonderful session.